This is Dr. John Eichhorn, do the podcast for the residents for exam preparation and for general knowledge about the anesthesia monitoring standards in particular. This includes specific extra information about the inspired oxygen monitoring mechanisms beyond the standard, because that apparently was part of exam questions in the written exam, and also related basic information about sedation, because that also apparently was in recent written exams. Why do we have standards of practice? Because the American Society of Anesthesiologists and the profession in general believe that these topics, especially intraoperative monitoring, are so important that it has to be enshrined, if you like, or institutionalized in formal standards that demand a requirement, minimum required practice. Now, that has medical legal liability implications in particular. Basically, the idea being these are mandatory, these are required standards for monitoring during anesthesia. And if you have an accident with patient injury while knowingly ignoring the standards for no good reason, basically you have no possible defense and it's an automatic loser. So that gives them functionally the force of law. There are a wide variety of standards, no, I'm sorry, a narrow variety of standards, a wide variety of documents from the ASA, and this is in the ASA website, which is listed there as asahq.org. It's under the publication section, the standards and so forth, and it talks about standards, guidelines, statements, practice advisories, and practice guidelines. Now, the practice advisories are very strong consensus opinions on various topics, some obvious, some not so obvious. They have the weight of recommendations, and because they're recommendations from the American Society of Anesthesiologists, that has legal implications. Not the same level as standards, but still legal implications. Now, the practice parameters, now called practice guidelines, are definitely key documents. There are more and more of them from the ASA. These are heavy duty in the sense that they're extensive evidence-based documents prepared by a big task force of lots of members, erudite, study every single possible reference, have professional statisticians, professional reference librarians, and it puts it together in attempting to prevent a fair and balanced, as they say, presentation of current opinion about whatever the topic is. And they're extensive qualifiers in the sense that they evaluate the kind of evidence, the strength of the evidence, classification of the evidence, and explain all that in the practice guideline. And that gives them sort of the weight of sort of recommendations. Recommendations in particular from the advisories have stronger weight, and standards have by far the strongest weight of all. Yeah. So this is the section in the website. This is an older version, but you'll see the new version in a second. And the idea about departure from one or more of the recommendations may be appropriate if the facts of the circumstances demonstrate that the care met the physician's duty to the patient. Well, that's a legal qualifier to make it clear that they're not telling you you have to practice this way, but they're making strong recommendations. And this is not counting the monitoring standards, which are, as I said, with the force of law. As it says here, standards are rules, minimum requirements, generally accepted principles, may be modified only under unusual circumstances, extreme emergencies, or unavailability of equipment. Guidelines, it says, are the recommendations. We talked about that. As far as they're not intended as standards, it says that very carefully, or absolute requirements, and their guarantee cannot cannot guarantee any specific outcome. The guidelines are subject to revision, and they provide basic recommendations, as it says there, with the background. Statements are less powerful, if you like, because they are the best judgment of the Society's officers and House of Delegates. They don't have the same review and evidence-based, strong assembly of all the possible references and that kind of thing. That's what the organization wants to put out as the organization's opinion. That is not the same level at all as a practice guideline. This is what the website now looks in 2015. When you go in the so-called guidance documents, or in the section that has from the main page, it says all standards, guidelines, and practice parameters, and it groups them, as you can see, by the various categories. It's actually not as useful as it used to be, because it sort of mixes up the various levels. There is a way to look at it differently, but the list from 2011, which we'll go over very briefly right now, illustrates how they have various topics and all kinds of different topics. And if you look through this list in the ASA website now, you'll see that there's even more topics in all of those various areas. This is a list of 2011, and it goes on and on. The important one is the basic anesthesia monitoring, which was last modified in 2011, and that's part of the list there. This is another part of the list, and it includes things about documentation of anesthesia care, which record keeping, economic credentialing, which is very important. For example, when you go to sign a practice agreement, ethical practice is one of the main ones, granting privileges and privileges to non-anesthesiologists for sedation, which we'll get to later, infection prevention, so on and so forth. You can read it faster than I can read it to you. And position of monitored anesthesia care, in the sense that there's some insurance companies that don't want to pay for MAC because they say it's not anesthesia. Well, it is, and this is the document that proves it. The things about obstetrics, organization, pain, various other things, even a statement on practice parameters to illustrate the explanation of what is important as far as what they mean to explain to other people outside the profession. This is another, at the end of the list, of examples of things on topics that there are document statements from, and of course guidelines and ultimately standards for certain of them. Safe use of propofol, for example, is very important when the anesthesiologist community has issues with the gastroenterology community that uses sedation nurses that want to use propofol in GI suites and have problems that lead to accidents and ultimately lawsuits. So there's a issue about safe use of propofol. The practice parameters are the stronger ones, and things like perioperative visual loss and suggestions about doing huge spine cases with positioning, blood pressure, visual, and blood loss, and all those kind of things that impact the potential for that. Pre-anesthesia evaluation, of course, is a big one, and there's one about the preoperative fasting. I think that's one of the more recent revisions. Blood transfusion. I mean, these are the heavy-duty documents, and that and there's an important one here. It says revised, and this is a couple of years ago, about perioperative management of patients with electronic cardiac devices. This is, again, is the finishing of that list. And you got practice guidelines for management of difficult airway, which is, of course, the famous one. Perioperative management of patients with obstructive sleep apnea is an important one. A lot of legal implications there. If patients have difficulty breathing in the immediate postoperative period, or especially the first night after surgery, that's covered extensively in there, about the idea of monitoring, and also even monitoring for pain patients getting PCA now. So that's down here in the practice guidelines for the prevention, detection, and management of respiratory depression associated with neuraxial opioid administration, especially the idea of epidural PCA, and so on and so forth. And there's a practice guideline for sedation and analgesia by non-anesthesiologists, which is critical because many people don't realize that the Joint Commission rules require that the chief of anesthesia, so to speak, in any given organization is responsible for what the sedation nurses do even though they're not under anesthesia and they're not trained or credentialed by anesthesia. The anesthesia department, or in particular the chief of anesthesia, can be implicated if a sedation nurse has an accident administering sedation. It's a difficult situation, and if you're ever in a situation that subject comes up, you've got to read this document or its updated version by the time you get there to understand what the details are and what the implications are. I got lots and lots of examples. This is the one about visual loss associated with spine surgery. All these are, of course, in anesthesiology. The references here, but the references are also reprinted on the website. I just click on it and you get this, and it goes over all the issues associated with visual loss. And I think it's a very important one because surgeons who do the big spine surgeries cannot be counted on here or anywhere to get genuine informed consent discussing the potential, small but nonetheless definite, for visual loss associated with that particular spine surgery. So if you're ever in the situation and you wonder what are you really expected or need to do as far as not only getting informed consent but also managing the case, this is the document that you need to look at and have and study. Interoperative awareness and brain function monitoring, response to the huge BIS controversy some years ago. You can read this. It basically says that they're not endorsing BIS, but they're not saying it's worthless. It may help prevent awareness. They don't address the point that I like to make all the time about the fact that BIS is not really primarily intended to have anything to do with unintended awareness. It's just another vital sign that helps you manage the anesthetic. If it were to, as part of that application, prevent somebody from being aware when they otherwise might have been, fine, but that's not the main focus of using BIS. Nonetheless, this kind of thing comes out, which basically says in high-risk situations where it's obvious, yes, it's okay to use BIS, but it's not by any means an expectation from the American Society of Anesthesiologists that you use BIS in every single case as far as helping to prevent awareness. Again, controversy, coverage of all the published evidence, and even some testimony sometimes, and it's all listed in there. It's a very comprehensive document. It's a long document. This is about the, I mentioned about the management of pacemakers and EICDs. Again, long, complicated, very comprehensive document with all kinds of information that's directly relevant and important if you are concerned about what to do when you have a situation like this. Yes, there's a handout from cardiology here, but this is a good source also to have. Pre-anesthesia evaluation is obvious, but on the other hand, unfortunately, in a lot of legal cases, there is an accusation that the anesthesia team involved in a patient that went bad and had an unintended outcome and had an injury associated with whatever the care was, that the anesthesia people didn't do a thorough pre-op evaluation. And this is the outline of what's really expected as a minimum for that kind of circumstance, and above all documentation, so that you can prove that you did it. So these are the kinds of things that are in these documents from the ASA that you really need to be aware of. You don't need to have every document memorized by any means, but you need to be able to be aware that these are there, and you need to be able to get them and look at them when it's relevant. Here's one that's relatively new about infections associated with epidurals and spinals. That was an issue enough, kind of legal cases, that they felt necessary to go ahead and assemble this practice advisory, which has a significant amount of weight to it because it's one of the formal documents that really has a review of the entire applicable literature and thoughtful consideration of all the evidence with the subsequent advisory out of that. The peripheral neuropathies issue, seems not quite as severe as some of the other things, but the number of legal cases that are generated out of someone who has a permanent, allegedly permanent peripheral neuropathy, even though everything was apparently done correctly, during the case. The legal cases are very common against anesthesia personnel, and so this is an advisory about preventing perioperative peripheral neuropathies. No guarantees, but if you can show that you did everything that's in these this advisory and these recommendations, then you have the best possible defense against a lawsuit for a allegedly permanent peripheral neuropathy. This one is about reducing pulmonary aspiration and fasting guidelines and giving medications ahead of time. It's an older one because it's from 1999, but it's again the topic that you can see that the attempt to provide this information was in part at least response to the plethora of lawsuits for aspiration pneumonitis and bad outcomes. So here's one of the responses that again, has a lot of information in it. They all have a lot of information in it. One of my thing I think is very important is about prevention of fires. Everybody realizes, I hope, that there was a huge rash of fires with MAC patients getting peripheral procedures above the clavicles, a lot of lumps and bumps in the neck, port placements, even sometimes pacemakers, various other things that allowed there to be oxygen leaking from either nasal cannula or a face mask out into the field. They use a cautery, poof, the sponge, the towel, even the drapes catch fire and the patient gets badly burned. Well, enough of those things happened that the ASA recognized they needed to have a formal document like this. And it even says there about the fact that in October 2011 they were concerned enough about this to start doing this process, and they put out this ultimately as the response to the concern about fires. Now, getting to the heart of the matter, the standards for basic anesthesia monitoring are very important. And people don't understand that apparently there still are today situations in this country where anesthesiologists working usually alone in private practice do in fact leave the patient on a ventilator and leave the room. Patient's relaxed, must relax on a ventilator, hooked up, things on cruise control, and the anesthesia professional, could be CRNA, could be anesthesia attending, believes it's safe for them to go to the bathroom, go get coffee, or whatever, and leave the patient running. Well, that's a violation of Standard 1, and that's very important in the sense that, God forbid, there should be something happening that goes wrong, and we'll talk about that more in a minute. Same idea with starting an elective case without a pulse oximeter, and then later there being some kind of question about oxygenation causing damage. So we got physical presence, monitoring. The monitoring is for oxygenation, ventilation, circulation, and temperature. And we're going to talk about the capnography, including the capnography summary, being helpful. So this is the key document. This is the standards for basic anesthetic monitoring, which, as I said in great detail, have the force of law. This is the way it is. You do need to be familiar with this document. You do need to be familiar with the ideas and the wording of certain of the standards. Particularly, you have Standard 1, which is saying qualified anesthesia personnel should be present in the room throughout the conduct of all general anesthetics, regional anesthetics, and modern anesthesia care. And then it goes into a lot of detail about the objective and the conduct of it. And that's great, but that's the core of the first standard, meaning you can't leave the room while the patient is under your care and is receiving anesthesia. Sounds so simple, but sadly you'd be astounded. One, there questions come in all the time. Is it okay for me to go to the bathroom, in the middle of a long case when things are totally smooth and everything's fine? And even if I ask the circulator to stand up by the head of the bed and to holler out for me if something changes. No, that's not acceptable. That's a violation of the standard. And if that were to lead to an adverse event, there's no possible defense. Standard 2, oxygenation. This is covering oxygenation, ventilation, circulation, temperature. That's everything, all the key things. And the idea being that this is the thing, these are the topics, the areas, the parameters that need to be monitored at all times. So it talks about ensuring adequate oxygen concentration in the inspired gas and the blood during all anesthetics, and inspired gas monitoring we're going to talk about a little bit, but it says basically the concentration of oxygen in the patient breathing system shall be measured by an oxygen analyzer with a low concentration alarm limit in use. And then the same thing, quantitative method of assessing oxygenation such as pulse oximetry, um, and the pulse oximetry was used, the variable pitch tone and the low threshold alarm shall be audible, so that you can have that as an alert. And it includes even the ability to look at the patient's skin color if necessary. But that's very important as far as oxygenation is concerned. Ventilation, obviously, ensure adequate ventilation of patients during all anesthetics. And it goes on a very important concept. And this talks about have the adequacy of ventilation continually evaluated. Well, that uses the word continually, which is different than the word continuous, which is in a lot of the other things. And continual means repeated frequently in sequence. And the idea also is that continuous is what pulse oximetry is, what ECG monitoring is. And this says about continual monitoring of presence of expired carbon dioxide, unless it's impossible. And in the final accounting, that should probably be continuous, because if you could put on the end-tidal CO2, it should be on the whole time the patient's connected to the breathing circuit. And then the use of end-tidal CO2 to verify the placement of endotracheal tube or laryngeal mask from the time of its placement to the time of extubation or removal. Again, that's required. That's a mandatory standard. And the end-tidal CO2 alarm shall be activated also. Again, another important concept. Ventilation controlled by ventilator, continuous use, disconnect monitor, usually low pressure system with the monitor enabled. Regional anesthesia without sedation or local, and then continual observation of qualitative clinical signs is considered adequate. So it's not a requirement that you put on a capnograph monitor for someone getting a regional with no sedation with no sedation. But it says during moderate or deep sedation, the adequacy of ventilation shall be evaluated by continual observation of qualitative signs and monitoring for the presence of inhaled carbon dioxide unless prevented by the nature of the procedure of the patient, so on and so forth. That means that anytime you give any sedation with MAC or regional, this is regional, it covers MAC too, verifying that there's carbon dioxide coming out of the patient one way or another to confirm that the patient is in fact exchanging and ventilating is a standard. It is a requirement. It is mandatory. And God forbid there should be a accident involving inadequate ventilation during this time. If you don't have a capnograph on, that is a violation of standard that makes it indefensible. There would be no legal defense against a lawsuit. Circulation, same idea. You're going to have electrocardiogram continuously, and heart rate evaluated and recorded at least every 5 minutes. Every patient receiving general anesthesia has to have palpation, auscultation, but the idea being that the plethysmograph on the pulse oximeter is the evidence of a pulse, which is the evidence of cardiac output. And so that's where this idea comes from. Obviously, intra-arterial line covers the same idea, but this is a requirement. And so that's why the pulse oximeter display on the monitor is so important, because of the pleth tracing. is a required standard. Body temperature, it says, very important. Every patient receiving anesthesia shall have temperature monitored when clinically significant changes in body temperature are intended, anticipated, or suspected. Well, that could be pretty much everybody. And the idea being that, except in the shortest of MAC cases or cases on little kids that only take a few minutes, other than that, basically patients need to have their temperature monitored and recorded that you monitored it. And there's even the idea about continual versus continuous, and it makes it clear distinctions, and that's unfortunately important when it comes sometimes to defending lawsuits against anesthesiologists where the plaintiff's attorneys hold up this document, and then it becomes necessary to distinguish between continual versus continuous. And then, of course, there's the idea that pretty much, if necessary, and that's listed right there at the bottom, you can omit any of the monitoring or any of the required behaviors in the standards if there's a good reason, basically. And then if you do that, and the classic example, of course, is a case such as the big one in New York many years ago, where they started a case where the second case of the day when the capnograph stopped working after the first case of the day. Well, of course, it had to be that case where probably, I believe there was, a unrecognized esophageal intubation in the patient that had the capnograph that was broken. And unfortunately, that makes it completely, totally indefensible. That was a big loser for that anesthesiologist and that hospital, anesthesia department. So, but the idea being that if you are going to deviate from the standards knowingly for a good reason, you got to make a note of that in the record. That's basically what this says at the bottom there. Okay, now the specific question that came up, some questions that came up in the exam about inspired oxygen monitoring. There are two kinds of oxygen analyzers. The basic one that is almost always now used is called a fuel cell or galvanic oxygen analyzer. That's what we have. It's in the proximal inspiratory limb. It's basically got a probe that goes down into the inspiratory part of the breathing circuit, and there's a membrane, and oxygen goes through that membrane freely, and there is a positively charged metal cathode, and then those ions actually oxidize a base metal anode. And the process of oxidation allows an electric current to flow. And the flow of electric current, as it says there, is directly proportional to the number of oxygen molecules, and that once it's calibrated, and it's usually calibrated to 0, 21, and 100, or close to 100 as you can get, then the monitor will read the percent of inspired oxygen. It's relatively slow, and the sensor does get consumed and it has to be changed, but this is the classic inspired oxygen monitor, and I suspect if there were an exam question, it would have to do with the technique of the idea that you have a negatively charged anode that is physically consumed, burned if you like, which consumes oxygen, and the amount of the oxygen directly determines that flow of electric current. There are other ways to measure oxygen. There's the so-called polarographic, which is electrochemical, very rare anymore, unlikely to be the subject of a question. The paramagnetic oxygen analyzers are what's in the gas analyzers, and you know the gas analyzer has an inspired oxygen concentration on it, and there's two sources of inspired oxygen concentration on the anesthesia machine. Most people don't realize that. And the idea being that you can read there how it works with the comparison of the various sources. It's there. It's possible that that could be an exam question to contrast that with the standard fuel cell one. I doubt that, but that would be a pretty deep question. But now at least you've heard about it. It's easy to calibrate. You usually check it to 21 and 100, and the fuel cell type, as it says, wears out and has to be changed out when it no longer reads 100. Now, since we have the opportunity here, I'm going to give you a bonus. This is a summary sheet about capnography. This particular summary sheet, which we have in bigger detail in a minute, doesn't exist anymore. You can't get this anywhere anymore. So I think this is an incredibly valuable sort of cheat sheet, if you like, and I would suggest perhaps that you could print out this page and fold it up and carry it with you, or put it on your phone. Better yet, if you can read, you can make it big enough and blow it up and still read the print, because it is a very good reference source to have with you in the OR when you're looking at capnograph tracing. For example, here's the kind of information about what's in the capnograph, where you have the inspiratory and expiratory, and then it shows you where you're reading the end-tidal CO2 at the end of expiration, and then the sharp inspiration, and it goes on, of course, to give various other examples of what the capnograph looks like when there's a problem. And if there's disconnect, misconnect, obstruction in the breathing circuit, that's number 3 here, very important one. And leaks, defective inspiratory valve, defective expiratory valve, that's classic exam question stuff right there, where you have a capnogram like this in the question and saying, what's this? And it gives you choices. So if you get anything out of the capnogram example, this would be the stuff to remember, in particular the difference between what the capnogram of the expiratory valve looks like versus the expiratory valve problem. Endotracheal tube, right main stem, certainly in the patient chest is a good one. Soda lime, that would happen over a lot of time. That's a compressed record, excuse me, but that's what the capnogram would look like. Various COPD, of course, difficulty breathing, bronchospasm, large airway, ventilatory arrest, so on and so forth. You can look at them faster than I can read them to you. CPR, what looks like that, what a pulmonary embolus might look like. Metabolic defects like MH, where you just get sudden flood of expired carbon dioxide. Hypothermia decreases the, and so on and so forth. The so-called Curare notch in frame D here, where the patient is fighting the ventilator and trying to breathe against the ventilator. So that brings us to another key point that apparently has been the subject of exam questions, and that's that there is a very complex political and economic series of issues around IV sedation. It's very complicated. There are lots of implications and issues about the so-called sedation nurses that they have in GI suites, in bronch suites, cath labs, and IR in some places, and so on and so forth, especially places that are not big teaching hospitals like ours, where they don't have anesthesia personnel that are willing to go to the so-called safari or offsite or satellite or whatever you want to call them locations and do these kind of cases. So the issue frequently is that the so-called sedation nurses are not trained to manage airways. They're not trained to recognize hypoventilation, and above all, they're not trained to use propofol, but nonetheless they try to do all that. And this is a problem, and it sometimes becomes the problem for anesthesia first when there's a bad event, and they have to hustle and try to resuscitate the patient, or after the bad event, especially if the patient is damaged. The question comes, well, why didn't anesthesia create protocols and credentialing for these sedation nurses that are using these powerful drugs without really understanding what they're doing. It's very complicated. There's no possible way we could go over all the implications of this, but you do need to realize that all the way back to 2002, there were practice guidelines published by the American Society of Anesthesiologists for sedation and analgesia by non-anesthesiologists. Now, does that mean CRNAs, or does it mean sedation nurse, so-called RNs that are so-called trained for sedation? Well, it gets more complicated. And then very intense in the last few years, 2010, 11, 12, 13, all these advisories and statements on granting privileges for moderate sedation anesthesiologists, granting privileges for deep sedation, which would have to be like to the cardiologists, to the pulmonologists, to the gastroenterologists in particular, who claim that it's perfectly safe for them to direct nurses using propofol. That's one of the biggest issues. It's not settled. It's an ongoing controversy. And the top one from 2013 has a lot to do with labor and delivery nurses, where in private practice it's not that rare for an anesthesiologist to come in, put in an epidural, hook up a pump, explain to the labor and delivery nurse, hopefully they know already how to run the pump, or they've been trained to run the pump, one would hope, but what to do, and to call them to get telephone orders to increase or decrease the infusion from the pump into the epidural, or bolus if necessary, or turn it off if it's going to be delivery or whatever. But these are the kind of highly controversial, sometimes inflammatory topics that are covered in these documents from the American Society of Anesthesiologists. As I said, there's no possible way we can go over all this. But as far as the idea of the monitoring, it is relevant for you, and this is something you really do need to have in your mind, in the sense that this is where an exam question was first come, I think, from the ideas about sedation. Again, sedation complex, monitoring requirements are not the same as during general anesthesia, but do note that the ideas I emphasized earlier about the monitoring of ventilation via the qualitative display of expired carbon dioxide whenever it's physically possible is a requirement of the monitoring standards and is therefore a standard of care. That is not universally understood, and it's certainly not universally applied, but the people who go ahead and do so-called procedural sedation without monitoring, at least qualitatively, the expired carbon dioxide, are basically asking for trouble, because sooner or later something is going to go wrong with somebody having inadequate ventilation, and if there were to be an event that caused harm to the patient, they're going to have no defense. So these are the so-called 4 stages of sedation. It's a continually addressed topic at the American Society of Anesthesiologists, including at the annual meetings. This happens to be from last year's annual meeting. They again worked on this, and minimal sedation with anxiolysis. It shows basically that the ventilation is unaffected, airway is unaffected, so on and so forth. Moderate sedation, conscious sedation, that's allegedly what the nurses can do, and the idea being that purposeful response, and there's an emphasis on what does that purposeful mean. In fact, that's down here as far as reflex withdrawal from a painful stimulus is not purposeful response. So here saying that's a requirement to make it moderate sedation, conscious sedation, and that is what some RNs are so-called allowed to do. No airway intervention required, spontaneous ventilation is adequate, and cardiovascular function should be maintained. Okay, so then comes the question about deep sedation, and forgetting the idea that RNs alone are some places doing it, but basically inappropriately, and the idea being that gastroenterologists in particular are able to direct deep sedation, and that is the definition of deep sedation. And note that it says airway intervention may be required, spontaneous ventilation may be inadequate. That's what deep sedation means. And so that's where the gastroenterologists or pulmonologists or invasive cardiologists or invasive radiologists get in trouble, because they're not necessarily capable of dealing with airway or ventilation issues in a manner appropriate, or certainly not equivalent to what an anesthesia professional could do. So that's the kind of thing that I suspect could be a question on the exam. And then obviously you know what general anesthesia is, and that's the other end of the spectrum. But the distinction, of course, the important thing is the difference between so-called moderate sedation or conscious sedation and deep sedation, because that's where the action is. And the idea being in all these documents that you always have to be ready for the next level down, which means if you're doing deep sedation, such as a gastroenterologist administering propofol for an ERCP, without any anesthesia professional there, they have to be ready to manage general anesthesia. Well, that's obviously a problem, which is why a lot of places, including us, don't have sedation administered, propofol administered by nurses, RNs, under the direction of gastroenterologists for ERCPs anymore, because it's too dangerous. There's too many events, too many accidents. So that's the kind of thing you need to understand. All the caveats go with this about the definitions, with the verbal definitions, but the important thing is that moderate anesthesia care has nothing to do with sedation. It is a specific anesthesia service, and that's very important from an economic and political standpoint. But that's important that MAC doesn't imply sedation. The issues about the definitions of sedation, so-called, and that shows, of course, the moderate sedation. For conscious sedation, you can read that, and it's basically a verbal expansion of what's in the table that we just looked at that you need to understand and have. This is the idea about deep sedation. General anesthesia is, obviously, you know what that is, and we talked again about what deep sedation is, and impairment of ventilatory function possible and may require assistance in maintaining a patent airway. Spontaneous ventilation may be inadequate. That's, you know, the issue with so-called deep sedation. So this is what I mentioned earlier about the safe use of propofol, because there's grave concern, including as recently as last October, about the non-anesthesia professionals attempting to use propofol and not being qualified to rescue. You see the big emphasis there on rescue. And, you know, if you choose to pause this and read all that, that's fine, but all this is on the website. This is simply to show you that all this information is there and to give you some idea about what might be in an exam question, I guess. Be difficult to write an exam question about non-anesthesia professionals, non-anesthesia people, meaning so-called sedation nurses, using propofol, but the idea being they've got to be ready to deal with the next level down, which basically they're not qualified to do. Okay, that's the requirements for ideas about sedation, and above all monitoring and sedation, and the things that you need to know as far as basics, and you above all need to know where to go to get this information when it becomes relevant to you out in the practice world. Okay, we have a great deal of information just gone over in the last 40-some minutes. You don't have to remember all the ASA documents and practice advisories parameters, but you need to know that they're there and that there's a huge list of topics now covered by these documents, and there's information there when you need it, and you go to the website and you get it. You do need to remember a lot about the standards for basic monitoring, and you always hear the shorthand, or you even write it sometimes on the record, you know, applied ASA monitors. Well, that's great, but you need to really understand what that means and what all the implications are, because there are details that could bite you if you don't understand them and you have something bad go wrong. Inspired oxygen monitoring we talked about. I would probably focus on the main kind of monitor that's used, and you need to understand that. The capnogram summary that I went over that is there, that I suggest you print out and keep with you or have on your phone, is a gift, because you can't get that anymore. And it's a very useful little happy thing to have with you, that if you have a funny tracing on the screen and you're not exactly sure what it means, you pull it out. All right, sedation we talked about, very complicated, a lot of political and economic overtones, and the clinical dangers, as we talked about in detail, of so-called sedation nurses getting in over their head real quickly, of dealing with airway problems and inadequacies of ventilation that they're not capable of dealing with, which leads to danger and ultimately occasionally accidents that can involve anesthesia, both for resuscitation and then ultimately the questions about were they responsible for what the sedation nurses were doing, even though they're not anesthesia people. And if you ever become chief of anesthesia at a community hospital, you absolutely positively have to understand the exact wording of the Joint Commission standard on that topic. So you need to understand it. That's it. I'm always open to questions. You know how to find me. Cheers for now and good luck. Thanks.